Hello, my name is Hayden Fox. I'm a second-year OBGYN resident at OSU. I am here today talking to you about reproductive endocrinology, the female menstrual cycle, and hormonal contraceptives, their uses other than contraception for any medical problems that you may arise or may see that you could use oral contraceptives or other hormonal contraceptives for. For reproductive endocrinology, I'm just kind of going to hit the basics of the hormones, what they do, where they act, pretty much the HPO axis, and I'll go over that whenever we get there. Go into a little bit more detail in the menstrual cycle, talk about normal, what you should see in reproductive aged people. And then we'll talk about those hormonal contraceptives and the different types and when you use them and when you can't use them. So we'll just get right in, start with our objectives here. As you can see, we'll review reproductive endocrinology, we'll just go over the basics, review the menstrual cycle, and like I said, we'll review those hormonal contraceptives. So starting out here, we're going to jump right into reproductive endocrinology. So here's a picture from every medical textbook that has talked about endocrinology. You have at the top here your hypothalamus, which releases your GnRH, which acts on the anterior pituitary, which releases, for this lecture, LH and FSH, which then is released into the periphery and interacts in the ovaries to release estrogen and progesterone. You have a positive feedback loop, you have a negative feedback loop, which I'll talk about in later on in this lecture, but it's pretty much how the female reproductive cycle occurs with the estrogens and the progesterones, feeding back to the hypothalamus and the anterior pituitary. Just a couple of background information for completeness sake. The hypothalamus is considered the coordinating center of the endocrine system. It consolidates signals derived from upper cortical inputs, autonomic function, environmental cues such as light and temperature, and peripheral endocrine feedback. It delivers precise signals to the pituitary gland, which then releases hormones that influence most endocrine systems in the body. Hypothalamic hormones are small peptides that are generally only active at relatively high concentrations achieved only through the pituitary portal blood system, which is why we can't super accurately measure some of the hypothalamic hormones, specifically GnRH, when we are looking for problems with GnRH specific medical issues. And that's about all of the background information for the hypothalamus. For the pituitary, obviously we have the anterior pituitary, so we have the posterior pituitary, different in hormones that they have receptors for, different hormones that they release. But again, for this lecture, we're going to be talking about LH and FSH. Biggest difference between anterior and posterior pituitary is they come from a different embryologic developmental site, which is why they have different functions. So through the next few slides, we're just going to talk about each one of these hormones individually, what they do, what effects they have, and we'll kind of go from there. So the first that we're going to talk about is GnRH, gonadotropin-releasing hormone. It's released from the hypothalamus in a pulsatile fashion. And the pulsatile is in italics because that's important for normal physiologic function. We've known just by drugs that we've used that mimic this, or antagonists, agonists, really anything that interrupts the pulsatile fashion disrupts the normal physiologic process of GnRH to FSH, LH, and then subsequently estrogen and progesterone. So that is a huge area of pharmaceuticals where you can target via agonists, which these are listed down here, to disrupt this normal HPO or hypothalamic pituitary ovarian axis, which can be used to treat these things that we'll talk about in a second. So like we said before, appropriate pulsatile release of GnRH stimulates the release of luteinizing hormone and follicle stimulating hormone, from the anterior pituitary. This hormone has a short half-life, about 2 to 4 minutes, and like I said, it's very reactive. It's only reactive at very high concentrations, and so that's why we don't see any other effects in the body when you have a short half-life and only effective in high concentrations. That's why really it only works in the posterior pituitary, and that's where we really only see receptors. So we can't measure GnRH accurately, so we use serum LH as a surrogate marker for hypothalamic GnRH secretion. GnRH secretion has significant influence from outside the brain and outside the pituitary as well, with all of these peptides and hormones that are listed here. I'm not going to read them off, but just to know that there is significant room for error or room for modulation, I guess, for GnRH secretion. So then, kind of like we talked about before, if you mess up or if you disrupt this pulsatile fashion released from the hypothalamus in its normal physiologic state, you suppress the release of estrogen and progesterone, which you can do with any of these 3 drugs. This big one, probably most common that people recognize, leuprolide, is Lupron. Can be an injection for up to 3 months. It totally disrupts the HPO axis. It can be used for precocious puberty, breast cancer, fibroids, and endometriosis. Essentially just cuts off the estrogen supply with a agonist, which is fairly interesting. So that's about all I'm going to talk about with GnRH. So we will move on to FSH and LH, which are our anterior pituitary hormones that we're going to visit a little bit today. So FSH, a little bit of background for it, promotes follicular development in the ovaries, interacts with the ovaries with release of estrogens from the granulosa cells. And then you have your LH, which helps with ovulation, stimulation of androgens from the theca cells, and maintenance of the corpus luteum after ovulation. And then again, like I said, it releases this progesterone. That's about all I'm going to talk about with those. So next we're going to talk about estrogen and progesterone. So you have estrogen released by granulosa cells in the ovary, encourage endometrial proliferation, but they also have receptors in the cardiovascular, skeletal, immune system, GI, and neural sites. So it's not just a reproductive organ, as I'm sure you all know. And then you have progesterone released by the theca cells, stimulated by LH surge, which can be seen down here. I'll go over that in a second, and maintains endometrial lining while present. It's also secreted by the corpus luteum. So this is just a tiny picture. I have a much more significant picture later on in the lecture where I dive deep into the menstrual cycle, but essentially you have this LH surge here after ovulation, which stimulates ovulation. And then ovulation, you have your egg, your oocyte, and then you have your corpus luteal cyst, which is remaining, which produces your progesterone, which is this kind of bell-shaped curve. Like I said, we'll talk about that a little bit more in detail when I go over the menstrual cycle here in a bit. The next slide, these are places in the body that the estrogen that's created from the ovaries can affect. So you have central nervous system, you have hypothalamus, pituitary that we've talked about, you have immune system that's affected, cardiovascular system that is kind of I guess a hot topic for, contraceptive pills requiring estrogen. You have your mammary glands that are affected, and then obviously your reproductive tract that can be affected. So I felt like this was a good slide that kind of incorporates how estrogen affects really a majority of, or a much more complete area of the human body other than the female reproductive tract. And then I have a cross-section diagram of an ovary. It's, not super relevant, but here I have circled the granulosa cells and the theca cells here, which produce the estrogen and the progesterone. And then here's a good representation of that corpus luteal cyst following ovulation that produces that, helps produce that progesterone. So moving on, that's, like I said, kind of the basics of reproductive endocrinology. It's a very massive kind of subgroup of OBGYN, and that's kind of the basics that we'll get to go over today. So moving on, we'll go over the menstrual cycle. We'll revisit a couple of those hormones that we talked about, and we'll just dive right in. So this is the diagram that probably everyone recognizes that just kind of goes over the ovarian cycle, your body temperature in relation to the menstrual cycle, your anterior pituitary hormones, ovarian hormones, and endometrial lining is in this bottom phase here. So it's broken up into two phases. You have the first half being your follicular phase, your second half being your luteal phase. We'll kind of go over averages and things like that in the next couple of slides, but we'll just start here at the top. Your ovarian cycle, you have your primary follicle that continues to develop into your primary follicle here. You have ovulation at day 14, which is releasing the egg, and the remaining becomes the corpus luteal cyst. This corpus luteal cyst is what produces your progesterone, and then your corpus luteum degenerates if you don't have implantation, or if you don't have fertilization and implantation. So that's kind of a life cycle in the ovary. Here you can see body temperature raises about 0.5 degrees Celsius after ovulation. So people that are doing natural family planning and people that are trying to conceive use this as a tracker of when they have ovulated. So then you have your anterior pituitary hormones, you have your classic LH surge that you have just prior to ovulation, which helps cause ovulation. So you have this right before day 14. You can see a little spike in FSH as well in the green there. You can see here in ovarian hormones that this yellow is estrogen, how it slowly peaks before ovulation, it drops, and then it kind of slowly raises with your progesterone in the luteal phase here in the second half. But then you have, like I said, you have your corpus luteum after ovulation, your progesterone is increased and decreases appropriately if you don't have fertilization and implantation. If you do have that, you have a pregnancy, the corpus luteum remains for the first few weeks of pregnancy until the placenta can take over, but that's for another day. And this last one, this last diagram here at the bottom is the endometrial lining. So this is the first day of your menstrual period here. After you have shed your lining, you're slowly building it back up in the follicular phase, and you build it up, and then you have ovulation, you have progesterone. This progesterone helps maintain the lining, and the decrease in progesterone is what ends up causing you to have your endometrial lining shed. So that I spent a lot of time on this, just kind of the basics. Probably a boring review for most of you, but I felt like it was important. before talking about any oral contraceptives or any hormonal contraceptives that we'll talk about later in the lecture. So moving on, here's another just representation of, you have your LH surge and then your progesterone in the luteal phase toward the end there, just another representation. So kind of in not a chart form, but the menstrual cycle is the first day of menses, represents the first day of the cycle, day 1. The cycle is divided into the 2 phases that we talked about, follicular and luteal phases. Follicular phase begins with the onset of menses and ends the day before the LH surge. The luteal phase begins on the day of the LH surge and ends on the onset of the next menses. The average cycle is about 28 days plus or minus 7 days, lasting 4 days plus or minus 2 days. The average estimated blood loss is between 20 and 60 mLs of blood. You have more variability in your cycle in the first 5 to 7 years after you start having your menstrual cycle, and for the last 10 years prior to menopause. But for the most part, unless there is a pathologic reason for irregular menstrual cycles, that you have fairly minimal variability between ages 20 and 40 years old. And then you have shorter intervals of your cycle are common in early menopause, and longer intervals are indicative of a late transition into menopause. So just kind of the basics and some background information for us. Okay, so the next 3 or 4 slides are going to be way too much detail. I just included them as a kind of written description of what I talked about earlier in that diagram. So I'm not going to go into huge detail. I'm not going to read all these. I know this is a cluttered, mess here, but I just kind of wanted to talk about the differences in the hormonal activity and what the endometrium and ovaries look like during each phase of the menstrual cycle. So like I said, not going to read all this, but what I did want to go over is what the ultrasound evidence has showed us in each phase of this cycle. So just to kind of go over this early follicular phase, the very beginning, ovarian ultrasound has demonstrated that the ovary is quiet in the early follicular phase, except occasionally when you can visualize a resolving corpus luteal cyst from the previous cycle. Endometrium is relatively indistinct during menses and then becomes a thin line once your endometrial lining shedding is complete. And so you can kind of see up here, you have your uterus right here, your very thin endometrial lining right here. And so just kind of wanted to go over that briefly. Sorry, again, I know these next couple of slides are a lot. I'm not going to go over it. It's just kind of what we talked about in the graph a few slides back. So next you have the mid-follicular phase. And so again, we're not going to go over this, but I just wanted to go over the ovarian endometrial changes. Sorry about that. So ovarian and endometrial changes within approximately 7 days of the onset of menses, several 9 to 10 millimeter follicles are visible on ovarian ultrasound. The rising serum estradiol concentration results in the proliferation of uterine endometrium, which becomes thicker with an increase in number of glands. So we'll see in a slide or two the actual difference between the early phase, the middle phase, and afterwards. So we will move on to the late follicular phase. So this is just prior to ovulation. And again, we're not going to go over that. It's just the basics of what we talked about earlier. But by ultrasound, you have a single dominant follicle has been selected while the rest of the growing cohort of follicles gradually stop developing and undergo atresia. The dominant follicle increases in size by approximately 2 millimeters per day until a mature size of 20 to 26 millimeters is reached. So here you can kind of see this triple layer, which is classic of just before ovulation. You have your endometrium here is getting thicker. And so you have your uterus here, endometrium here, looks thicker than previously. So after that, you have ovulation, you have your luteal phase, your mid-cycle surge, and your ovulation. So I do want to spend a little bit of time on this one because I think it's important. But you have serum estradiol concentrations continue to rise until they reach a peak approximately 1 day before ovulation. And then you have your mid-cycle surge. Surge represents a switch from negative feedback control of LH secretion by the ovarian hormones to a sudden positive feedback effect, resulting in a 10-fold increase in serum LH concentrations and a smaller rise in serum FSH concentrations. Again, that's the classic LH surge. The actual way that it goes from a negative feedback to a positive feedback loop is not well understood, but it's theorized that it may have something to do with the GnRH representation at this time. So our ovarian and endometrial changes here are your LH surge initiates substantial changes in the ovary. The oocyte in the dominant follicle completes its first meiotic division. The oocyte is released from the follicle at the surface of the ovary in approximately 36 hours after the LH surge, travels down the fallopian tube to the uterine cavity. There's close relation of the follicular rupture and the oocyte release to the LH surge. As a result, measurements of the serum or urine LH can be used to estimate time of ovulation in women. So at this point, your endometrium, the gradually increasing serum progesterone concentration have profound impact on the endometrial lining, leading to a cessation of mitosis and organization of the glands. So here we go in the luteal phase. You can see it's a little bit different picture of an ultrasound, but you have uterus here, and this is your endometrial cavity here, and you can see that that's much thicker at this point in the menstrual cycle. So then again, if you don't have fertilization, starts to degenerate in the late luteal phase here. So endometrial changes at this point. The decline in estradiol and progesterone released from the resolving corpus luteum results in subsequently in the loss of endometrial blood supply, endometrial sloughing, and the onset of menses approximately 14 days after the LH surge. So that's the withdrawal of estrogen and progesterone. Progesterone is a major key factor there, is that you lose your blood supply, and that's when you have your menstrual period. And here is another ultrasound, just comparing them side by side here. You have early proliferative or follicular phase here, real thin endometrium. Endometrium starts to get thicker, and then endometrium is at its thickest toward the end of the luteal phase prior to fertilization and implantation. Like I said, if there is none of that, then you start back over in phase 1. So here's another graph of what we've talked about. I'm not going to go over it again, so just here for completeness sake, I guess. So kind of switching gears, we will talk about hormonal contraceptive methods toward the end of this lecture. Their contraindications, what patients would be good patients to be put on combined estrogen progesterone, the options that you can use if you don't have a patient that you can use estrogen on, and we'll kind of just walk through the basics again, but in a little bit more detail to kind of help us out here. So we'll start with combined hormone pills, and we have progesterone only, transdermal patches, intravaginal rings. These two are probably the most commonly used in our patient population for sure. So we'll get started with the combined hormonal contraceptives. So in the United States, there's 3 forms that you can use: oral pills, transdermal patches, intravaginal ring. So the way that these work is they inhibit ovulation by suppression of the hypothalamic gonadotropin releasing hormone, which prevents pituitary secretion of FSH and LH. You have estrogens that suppress the FSH release and stabilize the endometrium to prevent intermenstrual bleeding, referred to as breakthrough bleeding in this setting. And you have your progestins that inhibit ovulation by suppressing the LH, thicken your cervical mucus to deter any sperm passage, and they render the endometrium unfavorable for implantation. So that's kind of how they work. The most commonly used estrogen in combined hormonal contraceptives is ethinyl estradiol. And the most commonly used progestin is this 19-nortestosterone derivative. So we'll go into a lot of detail about these. So kind of starting off, what you need to do when you are prescribing someone with any form of estrogen in a combined pill or a patch or really anything is that very basic screening requirements, and combined oral contraceptives are available over the counter in a majority of the countries worldwide, but about 30% of the countries, including the United States, require a prescription. So the things that you need to know before you have a prescription given to someone is you just need to have a good medical history. You don't actually have to do a pelvic exam. You just need to know the medications that they're taking, whether or not they have been a smoker, any high blood pressure, diabetes, any sort of blood clots, migraines with aura, breast cancer status, postpartum status, are really the big things that you need to know. The other thing is that it's not routinely recommended to test for coagulation disorders prior to starting someone on a combined oral contraceptive. So if they've never had an issue with clotting before, you don't need to test them, or just the general population before starting. You need to do a blood pressure and a BMI assessment. And then it's not recommended, but it's encouraged whenever you are writing a prescription for someone to get a oral contraceptive pill to do a breast exam, a pap smear, sexually transmitted infection screening. Again, not necessary, but something that would be in good practice to do if the patient was coming in for a well woman or just a yearly exam or something like that. So you have a couple of different populations here in this slide and the next slide, that you have unacceptable risk population and a risk outweigh benefits population. So these are kind of the big time do nots with any sort of estrogen systemically that you're going to be giving. It's going to be age over 35 and a smoking 15 cigarettes per day. Any risk factors for arterial cardiovascular disease, old age, smoking, diabetes, hypertension, any uncontrolled high blood pressure, any personal history of venous thromboembolism, any known ischemic heart disease, history of stroke, valvular disease, current breast cancer, severe decompensated cirrhosis, hepatocellular adenoma or malignant hepatoma, migraine with aura, or diabetes with 20 years duration, or with neuropathy, retinopathy, or neuropathy. So these all make sense, especially when you think about where estrogen has receptors throughout the body, but it's just nice to have them all in one place. Be like, if they have any of these, then you probably shouldn't use anything with estrogen in them. So on the next slide, we have the higher risk population, but risk can potentially outweigh the benefit. So you have over 35 and smoking less than 15 cigarettes per day, high blood pressure, but not in the 160s over 100s, high blood pressure that's adequately controlled on medication, past breast cancer and no evidence of current disease for at least 5 years, current gallbladder disease, malabsorptive bariatric surgery, superficial venous thrombus, or inflammatory bowel disease with risk factors for VTE. So again, these are the ones that if a patient is okay with doing a different method, then that method may be acceptable, but your risk could potentially outweigh the benefits. So next we're going to talk about the dosing, how you go about doing it, cyclic versus continuous, and we'll kind of just go from there. So the very first thing we'll talk about are monophasic versus multiphasic pills. So monophasic is pretty much all, the newer drugs are going to be monophasic, because in the past you used to have a much higher dose of estrogen in your pills. And so the theory was, if you do it multiphasic, let me back up and describe this a little bit better for a second. So you have monophasic pills, which are the same concentration of estrogen and progesterone in each pill for your 3-week time period, your 21 days, or to 24 days here. Your multiphasic pills vary in the dose of either estrogen or progesterone, more commonly estrogen. And if you have your first week of pills here being one concentration, your next week can be a different concentration. The week after that can be a different concentration. So this multiphasic regimen is a little bit outdated, and pretty much for the most part we use monophasic pills with the lowest amount of estrogen that's possible. And we'll go into that in a little bit more detail. So I just wanted to touch base quickly on that. That's really all I'm going to talk about with it. So next you have your cyclic versus continuous use. So cyclic use is your kind of typical, you have hormonal pills for 3 weeks, and then you have placebo pills for 7 days. You have your withdrawal bleed, and that is pretty typical. So an alternative that's been popping up in the last few years is an alternative that is a 24 estrogen progesterone regimen with a 4-day placebo pill that allows you to have a 4-day cycle, which has been shown that it's less likely that folliculogenesis will occur. It's increased efficacy, and the shortening of the hormone-free interval may reduce the symptoms associated with hormone withdrawal. The mood symptoms, the headaches, the pelvic pain. And so they've done some solid research on the differences between these two, and they found that a full 7 days of estrogen free is not necessary for the withdrawal. But one thing that they have found is in this 24/4 regimen that you can have more unscheduled bleeding due to what is thought to be because of endometrial atrophy becoming more likely, and with just the 4 days of your bleeding time. So then you have your continuous, which is taking a hormonal contraceptive every single day for up to a year. And so you can, if you choose, not have any withdrawal bleeding whenever you have your placebo pills, whether it's 4 days or 7 days. It's been found by research that menstrual suppression is safe. Withdrawal bleeding by the hormone-free interval, those placebo pills, is not medically necessary. But one of the things that they have found is that you can have unpredictable bleeding possible for the first 3 to 6 months. You can also do an extended cycle preparations that are similar to the continuous regimen. Essentially what you do is you have an 84-to-7 ratio. And so you'll take estrogen progesterone pills for 3 months, and then you will have withdrawal bleeding for 7 days. And so they're constantly working on different ways to improve this for patient satisfaction and to decrease, any symptoms of your menstrual cycle through these. Okay, moving on. So now we'll kind of get to kind of wrapping this lecture up here. Have your combined oral contraceptive pills used by approximately 16 million women in the United States. Again, here's this monophasic, biphasic, triphasic. Some companies have placed iron tablets and others have placed folate in the active and placebo pills to help with iron deficiency anemia and to decrease the potential neural tube defects with the folate here. But again, that's a different lecture. So your daily estrogen content in most of your combined pills are going to vary between 20 and 50 micrograms here. And then most pills contain 35 or less. So for the most part, you're going to be shooting between 20 and 35 from the ones that I have seen personally. In 2011, FDA approved a first pill containing the lowest dose of estrogen possible at the time, which is 10 micrograms. And here's the trade name for that. A lot of questions that I get when starting patients on contraceptives are, when will my normal menses restart? And typically with combined pills, it's pretty quick. Most women are between 30 and 90 days. If you haven't returned to your normal menstrual cycle within 90 days, then a more significant amenorrhea workup needs to be completed. So here's a couple of things about when to start it, your contraceptive pills. So you can have first day of menstrual cycle, which that makes sense. You can have a Sunday start, which is the first Sunday following the onset of menses. But the kind of caveat for that is that you need to have an additional method, whether barrier method or just refraining from intercourse for a week after starting for additional contraceptive protection. Quick start, which is starting at any day of the cycle. And again, another method will be used for a week. And then after a pregnancy loss or abortion, pill can be started within 7 days. And postpartum, most combined pills are started around 3 weeks after delivery. If you have any risk factors for blood clots, that you should really start around 30 days. And that's kind of another lecture in postpartum there. But so this is another question that I get very frequently, so I thought I'd include it. If you miss pills, if you miss a single pill, you should take that pill as soon as possible when you remember it. And then you should continue taking one pill each day. If you end up taking 2 pills in a day, let's say you normally take your pill at night and you woke up the next morning and you forgot, you can take a pill in the morning and at night, but no additional contraception is required because one missed pill does not reverse ovarian suppression. Missing 2 or more pills can be a little bit more problematic, but you don't need to take them all at once. If you forgot a week's worth, you don't take 7 pills. You just start back up where you left off. And then this is very important here, as a backup contraceptive method should be used. And then talk a little bit about emergency contraception here, but we'll not get much further into that. So here is a list of all of the contraceptive pills that are listed on UpToDate. You can't see it very well, but I just wanted to show you how many there are. And so when I am going through a patient and prescribing a contraceptive, I typically will use one that I know that, you know, Medicaid or whoever's insurance they have will pay for it. And I don't have any ties to this, but one that I found is easily available and relatively cheap is Sprintec. It's a 28 microgram estrogen pill. It's a 21/7, so you have 7-day withdrawal. It's easy to use, it's patient friendly, and it's in between that 20 and 35 microgram estrogen concentration. So again, there are a ton. Just find 1 or 2 that you like, that you know that insurance will cover and that patients can use fairly easily. So moving on, we have the progestin only pills. These are helpful for people that cannot get estrogen. It's not super common. As you can see, 0.4% of women in the US use this. Mechanism of action is they do not reliably inhibit ovulation, cervical mucus thickening, and endometrial atrophy. So this is the pill that you think of when you have to take it the exact same time every day. So even like it says here, 4 hours later, a supplemental form of contraception must be used for the next 48 hours. So it's going to be less effective, but if you can't have someone on estrogen and they don't feel comfortable with any other method, then this would be a reasonable option. Then we have our transdermal patch here, which is estrogen progesterone in a patch like you see here. Pretty much the same method of action as the pill, except you just have to put it on once a week. You can place it on the buttocks, the upper outer arm, lower abdomen, or upper torso. Here's the dosages here. You also have to note that if you have improper adherence, you'll get lower hormone absorption and efficacy. And then you have a new patch that's applied weekly for 3 weeks, followed by a patch-free week to allow for the withdrawal bleeding. So then we have the transvaginal ring. Again, I'm not going to talk too much about this because I have never used it, but it is available for patients if they ask. And then here is a chart from Up to Date that goes over all of the non-contraceptive benefits of cyclic estrogen, progesterone, contraceptives. So fairly significant list here of things that you can use with oral contraceptions that are not just for contraception. So I'm going to go into a few of these in a little bit more detail, but here it is just for completeness sake. So non-contraceptive uses, the big one that we see frequently are these menstrual cycle disorders and pelvic pain disorders. So if you're having abnormal bleeding or oligomenorrhea due to PCOS, menstrual cycle migraines, premenstrual syndrome or premenstrual dysphoric disorder, you can use oral contraceptives for all of these to help aid in the symptoms of all of these. And then another big one that we see frequently is pelvic pain secondary to endometriosis. Can also assist with ovarian cyst. It doesn't help with existing ovarian cysts. It only assists with the suppression of ovulation and subsequent formation of new cysts. It can also help with hyperandrogenism and the dermatologic manifestations of that, which are acne and hirsutism, are the two main ones that you hear of. Others can be hormone replacement with primary hypogonadism or premature ovarian insufficiency. You can have cancer risk reduction of endometrial and ovarian cancer, and then it helps with bone health in perimenopausal women. So here is the next couple of slides are the big ones on using estrogen, progesterone, and related medical disorders. So what you typically hear are the cardiovascular disease. It's contraindicated to use estrogen in women with a history of a MI. It can increase blood pressure, but not always clinically. So if you do start someone on a combined hormonal contraception, you need to have a blood pressure check in 8 to 12 weeks to make sure that it hasn't spiked. Patients that have controlled hypertension, like we talked about earlier, it's permissible to use, but those with uncontrolled should not be on any estrogen. So the second here we have cerebrovascular disorders, contraindicated women with history of ischemic or hemorrhagic stroke. And then it is contraindicated with women that have, migraines with auras, because there's a 2 to 4 fold increased risk for stroke compared to non-users. But if you don't have any focal neurologic changes or auras, it can be considered for young non-smoking women. And then again, here your DVTs and PE risk significantly increase in women who use these contraceptives. So risk were found to be estrogen dose related. So that again is important for the development of the lowest dose possible estrogen pills that we typically try to use. Let's see, that's about it on that. So then we have a few more here. Lupus, don't recommend with patients that test positive for anti-phospholipid antibodies because it increases your clotting risk. And then another one that's we hear about a lot is seizure disorders. If you use it concurrently with anticonvulsant, it may reduce the contraceptive or anticonvulsant effectiveness. So here I have listed the ones that are known that affect the contraceptive effectiveness, and here are the anticonvulsants that are found to be more appropriate with concurrent use. So then you have liver disease. Should not be used in women with acute hepatitis and women who experience a flare-up of their liver disease while taking their combined hormonal contraceptive can continue taking it. And then you have neoplastic disease, which say that you have protective studies against endometrial and ovarian cancer, but you should avoid in liver cancer, essentially. So then we're almost done. Just other forms of hormonal contraception. Here's a chart that we use frequently in our clinic for most effective, very effective, effective, and least effective. So the ones that we're going to talk about are the IUD and the injectable here, just because they are effective and we have a significant number of patients that use these. So injectable is your Depo-Provera. It's progesterone. It's given IM every 3 months and can, it works by inhibiting ovulation, increasing cervical mucus viscosity, and creation of endometrium unfavorable for ovum implantation. Yeah, there's just some more basics down here, but again, it's going to be one of those that it's helpful in patients that can't get estrogen, that maybe won't be as compliant because all they have to do is come back to the clinic for 3 months instead of taking a pill every day or switching a patch every week. And then the other one are going to be the hormonal IUDs. This one I find especially helpful in patients that can't get estrogen because there's no systemic effect. It's all local in the uterus. So here are the I guess the most common four. You have your dosages of progesterone here, your Skyla at the lowest here. Those first three are good for 5 years. The last one's for 3 years. So here's kind of when you can place it. But again, just for completeness sake, they're helpful in patients that can't get estrogen. So that is all. I'm sorry that it's kind of a lot, but I hope you learned a few things, and thank you very much.